Roberto, a close friend of mine. We will observe another aspect of the glaucoma world. Glaucoma frequently undergoes cataract surgery, so should we implant complex optics IOL in these patients? Because they ask for complex optics. They would like to improve vision as other patients not affected by the glaucoma do. This is my financial disclosure. So what are extended depth of focus IOLs? It's a word. We have monofocal IOLs. We implanted all of them until the year 2000 because centration was a problem at that time, and aspheric lenses or hyperaspheric lenses had to be centered. Then aspheric IOLs, they reduce the size of the focal point, thus reducing depth of focus. However, in glaucoma patients, I observed an increase of the visual field result in the eye with a spherical IOL as compared with the other similar eye with a spherical IOL. Then we have multifocal IOLs that have 2 or 3 separate focal points, and EDOF IOLs, and the definition pertains to those lenses that attempt to form a single elongated focal point to increase the depth of focus. So many lenses are now termed as EDOF. They can be refraction-based, and probably they are low-add multifocals. Diffraction-based, and still they can be low-add multifocals, termed as EDOF. Then they can be hybrid. Still they have diffractive rings, but some form of modification in the spherical aberration in the center. True EDOF lenses are those based on a modification of the spherical aberration in the central part or over the entire anterior lens surface. So EDOF lenses, in my opinion, should have no rings. Refraction-based EDOF may have a central near add, like the Lucidis, or a zonal near add, like the Lentis Comfort and the Acunex Vario. Those lenses, they work very well in many cases, not with the common problems, common photic problems of those type of lenses. However, they are very popular. For instance, the Lentis Comfort is termed as EDOF. In my opinion, probably shouldn't be termed in with that name. Diffractive and the hybrid EDOF IOLs, they have diffractive rings, and we have several lenses in the market. The Technis Symphony was the first one. We should remember that this lens has a diffractive distant focus, so the autorefractor will lie. The lens from Zeiss, from Hanita, from J&J, from the Swiss technology for Santen, they are all of them, they have diffractive rings. And it's the diffractive ring that probably affects in part a constant sensitivity because it affects MTF. And then we have the true EDOF IOLs, the aberration-based EDOF IOLs. I divide them into 2 categories as for now. The Presby EDOF, like the SIFI Miniwell, and the Medisem, the bioanalogic wavefront IOL, they have a rather huge modification of spherical aberration in the center. The SIFI Miniwell has a positive spherical aberration in the center surrounded by a negative spherical aberration adulus. The Medisem has a big positive spherical aberration through all the lens surface. This is probably too much. as I said, in Chicago in 2005, we can play with spherical aberration to increase the depth of focus, but at a certain extent. The lenses that probably are becoming more and more popular are the so-called the mono EDOF. They are monofocal with a central part or an entire surface trying to increase the depth of focus. And these are the most interesting lenses now in the market. They are not multifocal. They won't provide our patients a near vision, unaided near vision, but they increase the so-called social vision because the increase in depth of focus is above 0.5 diopter and goes up to 1.25 diopter. So how do they work? They try to elongate the depth of focus in this way, as compared with the monofocal, trying to minimally affect the image quality. This is the image quality with the EDOF, and this is the image quality with the monofocal. And we can see it's slightly better in this point and also in this point. They are slightly better. So let's talk about diffractive EDOF, because they are termed as EDOF, and they have advantages: pseudo-accommodation, spectacle independence if they work, visual efficiency. But disadvantages are the superimposition of focused and unfocused images that originates halos, starburst because of the rings and glare there is the need for a perfect centration and the need for a perfect ocular surface. This is very important in glaucoma, as nicely pointed out by my colleague. If we want to give our patient the best, we might require a secondary procedure on the cornea that is not welcome in glaucoma patients. Those lenses, those diffractive lenses, they do affect MTF, so the quality of the image transmitted to the retina is lower than the quality of the image transmitted by a spherical lens. And they affect, in turn, contrast sensitivity, and this has been demonstrated since a long time. My friend from Palermo, Italy, 2008, and this is a more recent paper stating the same thing with trifocal lenses. The visual field exam also is affected. Those are non-glaucomatous eyes, and we can see that this is phakic control, this is monofocal IOL, and this is the multifocal IOL. In 2014, this is another study stating that the mean deviation over time probably is increasing even a little more. So this does not heal. There is no accustoming to this type of problem. Quite recently, this interesting paper appeared. Those were lenses from J&J. So this was the J&J multifocal, this was the Symphony, and this was a monofocal. And this is a very important paper because it seems that the decrease in the mean deviation obtained with the EDOF lenses is very, very small as compared with the monofocal lenses. And the pattern deviation is the same. So it seems that EDOF lenses, diffractive EDOF lenses, they do affect the visual field exam, however, at a very low extent. That might be interesting for a lot of our glaucoma patients. However, many of our glaucoma patients, they have dry eye. Virtually all my patients treated with prostaglandins, they have dry eye. And for that reason, I'm very cautious in suggesting diffractive lenses to those patients. We don't know how the glaucoma will behave in the future. We don't know if we will be able to stop prostaglandins, and so for this reason, I would avoid those lenses in glaucoma patients, and I had a bad personal experience. Then we know that with diffractive lenses, the fundus imaging is not as good as with monofocal lenses. Is this important for our glaucoma patients? I don't think so in the long term, but if we are relying on OCT measurements taken, for instance, twice a year or 3 times a year, it might be more difficult to detect early changes with diffractive intraocular lenses. Oh, yeah. Because our glaucomatous eye has a lot of those problems that prevents us from using those diffractive lenses. And we have non-peer-reviewed literature that suggests even myols, multifocal IOLs, in selected cases. If we have an early glaucoma with a perfect visual field, a low risk for further damage and progression, and the demanding patient, I think we can use a diffractive EDOF or even a multifocal lens. However, peer-reviewed studies are few. I found only this one, reporting 75 eyes, and they didn't report visual field. However, they reported favorable results with multifocal intraocular lenses, and there were diffractive multifocals. Next slide. Previous one. However, there are 2 cases. Can you start the video, please? I would like to underline. One is pseudo-exfoliation. IOL centration, this is a completely decentered IOL bag complex. IOL centration, can you run the video, please? Might be. Great, thank you. Great. IOL centration might be a big problem in the long term. Glaucoma lasted 13 years 20 years ago, but now patients, they live longer, and so sometimes conditions like this one can be observed. Capsular tension rings are, in my hands, useless. I don't use them. If I need a ring, I can't put that type of lens. This is my conclusion. If we have a late subluxation or luxation, we will have in a very old patient with a very delicate eye. So I don't think that complex optic lenses can be used in pseudo-exfoliation unless we select the case, we select the patient very, very well. But what about ocular hypertensives? Luckily, we have this site that can help us in giving us the risk for those patients to develop glaucoma out of the ocular hypertensive study performed in the United States years ago. I use this site. I print the answer for the patient record. So diffractive EDOF IOL in glaucoma can be used unless there is a pseudo-exfoliation in a young patient, unless the optic nerve is heavily damaged, unless there are ocular surface problems, unless there is a heavy risk for progression, and unless the patient is not motivated, because there is no reason to put a lens the patient does not like. Aberration-based EDOF IOLs is a different story. In my opinion, Presby EDOF share indications and limitations with diffractive IOLs because they are complex optics IOLs, they need centration, they work well if the visual system of the eye is perfect. However, mono EDOF IOLs, the lenses that are becoming very, very popular now, they share indications and limitations with monofocal IOLs. And I think that those lenses will probably replace current monofocal even in our glaucomatous eyes. Thank you for your attention.
Roberto, thank you so much for your nice, beautiful presentation. If there are some questions.
Questions? Y a-t-il des questions sur la présentation du professeur Roberto Bellucci?
Yes, I have one question about the OCT after this type of intraocular lenses. On a souvent des images OCT sur des implants multifocaux qui sont perturbés. What do you think about it?
After diffractive lenses, the OCT quality is a little bit lower. After mono EDOF lenses, I have no experience because I implanted only a few of them so far. Most of my implants are multifocals. I have experience only with one, the ISOPure, and the OCT image is good. Great.
Okay. On a vu que le champ visuel pouvait être perturbé, il y a une diminution de la sensibilité au contraste, on a vu que l'OCT pouvait être perturbé, donc je vais lui demander avec ce nouvel implant, and for the visual field.
The modification is only in the center. So the visual field was found -1 decibel with a diffractive EDOF. I don't think the mono EDOF can be worse than that, but there is nothing in the literature so far.
Okay, thank you.
Est-ce qu'on pourrait résumer en disant, quel implant doit-on mettre quand on a un glaucome significatif en termes d'atteinte du champ visuel? What type of IOL can we use when the glaucoma is important?
I would suggest the mono EDOF at your choice. Mono EDOF at your choice. That's better for advanced cases. I also implant some multifocal. If the patient has a very low glaucoma, is 75-year-old, why not? But if the patient is 40 and he has a cataract, I would warn him against a multifocal. Sorry. Lenses can be changed, but we must warn the patient and tell him, if you want a multifocal, remember this will not be the last surgery in your eye.
Okay.
Je serai plus modéré.
Que dirais-tu?
Je mettrai sur un glaucome déjà évolué, je mettrai un monofocal.
Et ton point de vue sur les EDOF?
Alors, sur le dernier, on n'a pas assez de recul. Hein. Mais sur le multifocal, je suis plus restrictif dans les glaucomateux, parce qu'on peut avoir un glaucome, il va être stabilisé un certain temps et subitement, il peut évoluer drastiquement, donc c'est plus difficile. Quoi.
Donc tu dirais monofocal, ok. Y a-t-il des questions? Yes, your presentation was complete, so thank you very
Écoutez,
much.
Merci beaucoup. Et maintenant, on va laisser la parole à notre ami Renato De Natale qui va nous parler des problèmes de diagnostic différentiel et des problèmes de piège dans le glaucome. Merci Renato pour ton invitation.
Merci.